the biggest takeaway from our paper is that this is a multi-center collaborative effort with 7 different pediatric oncology centers, all of whom are using CD19-CAR T-cell therapies in children and young adults with ALL. And I think the multi-center aspect of it is particularly important because you really need to have large numbers of patients to be able to answer the question that we posed, which is, what is the impact of sequential targeting on outcomes for CD19-CAR? The registration study that led to the FDA approval of tisagenlecleucel, which was the Eliana trial, specifically excluded patients who have received prior blinatumomab. We know that blinatumomab, which is a CD19/CD3 T-cell engager, is associated with CD19 downregulation and also lineage switch. After receiving CD19-CAR T-cells, patients who relapse often relapse with CD19 negative DIM disease. And so the question that we wanted to ask is, knowing that any type of CD19 targeting can lead to CD19 modulation in the leukemia cells, what is the impact of sequential targeting of CD19 and the outcomes following CAR T-cell therapy? Because we don't really have contemporary data to help guide that to tell us about that outcome. But I think for real world practices, it becomes really important to know, because both blinatumomab and CD19-CAR T-cells can be used for patients with relapsed refractory disease. And so you may have patients who are receiving one or both. And the combination thereof may lead to very different outcomes than what we see from the Eliana trial. So based on our multi-center study, we had 420 patients, all of whom received CD19-CAR T-cells, and 75 of the patients had received prior blinatumomab. And the bottom line is that we found that blinatumomab patients, or that cohort of patients, did have worse outcomes as it relates to a higher relapse rate, were more likely to be non-responders to CD19-CAR T-cell therapy compared to their counterparts who did not receive blinatumomab, and they also had a worse event-free survival. We subsequently looked at the impact of blinatumomab on CD19 modulation and found that it was associated with CD19 DIM or negative populations, but we do need to look at that data a bit more closely. And so overall, where we're at right now is that, we have these findings, and we really need to understand, sort of from a biologic standpoint, what is the reason for this? We don't think it's just, simple enough to say that it all was because of CD19 modulation. But are the patients who received blinatumomab, they would have subsequently had relapse? Are they patients at higher risk for non-response to CD19 targeting? What exactly is that population? And if we know something more about them, does it mean that they're at higher risk of not responding to CD19-CAR regardless? And so we are currently in the process of putting together our more complete analysis for a follow-up publication from this abstract.